week's ACCP Emergency Medicine PRN Journal Club presentation. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/ACCP-EMED-PRN. And for PRN members, slides can be found under the Business Documents section on the ACCP Emergency Medicine PRN website.
The honor to introduce our first presenter, Dr. Megan Cavagnini. She is the PGY2 Emergency Medicine Pharmacy Resident at the University of Kentucky Healthcare. She will be presenting on intranasal ketamine for procedural sedation in children.
Thank you, Kyle. So like Kyle said, my name is Megan Cavagnini. I am one of the emergency medicine residents at the University of Kentucky. Today, I will be presenting on an article that came out a couple months ago in the American Journal of Emergency Medicine, and it is Intranasal Ketamine for Procedural Sedation in Children, an open-label multi-center trial. So just an overview of what I'm going to be discussing today. First, we'll go through a little bit of background and review a couple other studies that assessed intranasal ketamine specifically in pediatric populations. I'm going to go through the methods of the study and discuss what they utilized to conduct their study. I also will go through the results and present the results that they found, as well as take some time to go through the conclusions and takeaways and interpret those results from this study and apply it to our practice. With that, I'll go through a little bit of the background just to kind of let you know of some of the other studies that have been done, and then also how they relate to the study that I'm discussing today. And so the first study I wanted to bring up was done by Guthrie and colleagues in 2018. This was a prospective survey with a chart review, and it looked at 196 patients who were 6 months and older that received intranasal ketamine. These patients were given doses of 2 to 5 mg per kg with the option to repeat the dose at 0.5 mg per kg every 15 minutes if needed. And they found that 7.7% of these patients had a treatment failure, meaning that over 93% had success with this treatment. They also looked at the physician's standpoint and found that a lot of the physicians, 100% of the physicians, in fact, were comfortable utilizing intranasal ketamine for their patients. So that was sort of an interesting study that kind of just looked to see, can it be used? What's the safety? What's the efficacy? And then what do the physicians feel about it? Like I said, that dose was 2 to 5 mg per kg. Cristoforo and colleagues also did a study. It was single-armed, looking at patients 2 years and older that had lacerations and needed repairs. They also did ketamine 5 mg per kg intranasally, and they found that 80% of their patients had appropriate angiolysis. And so this was another study that showed, again, pediatric patients looking at the tolerability, looking at how effective it was. And then the authors for today's studies, basically what they wanted to do was find a little bit of a dose. So they did a dose finding study prior to this, and they found that 6 mg per kg intranasally was what they considered the optimal dose. And so what they wanted to do was utilize that specific dose. And I think it's a little bit unique because that dose, if you look at these studies and then some of the other studies, a lot of them were done in like dental infection or dental procedure type situations. Those studies didn't necessarily utilize that 6 mg per kg dose. And so I think this was a good opportunity to see a little bit of the higher end of the dosing scale. And so looking at the methods that these authors utilized, so like I said, their goal was to assess the safety and efficacy of intranasal ketamine for pediatric procedural sedation in the emergency department. This was a multi-center trial. It took place in 2 emergency departments in Canada, and it was a single-arm study. So they only studied ketamine. They did 6 mg per kg intranasally, and the concentration that they utilized was 50 milligrams per mil, and they had an open-label study, so there's no blinding in this study. And looking at who they included, so this, like I said, was a pediatric population. They had to weigh between 10 and 30 kilos. And I think part of the reason that they mentioned picking this weight was essentially the way that they did their ketamine. And so their ketamine was a 50 mg per mil concentration. And so what they would do is they would insert no more than 1 milliliter per nostril during their administration. If patients required more than 2 milliliters in their dose, what they would do is they'd wait a couple minutes and then they'd finish the administration after that. So they'd do 1 milliliter in each nostril, wait 2 minutes, and then finish with the remaining dose. But they did cap at 30 kilos. And then any child that was requiring procedural sedation for laceration repair with sutures was included. And so these were all LAC repair patients. In terms of their exclusion criteria, it was a pretty extensive exclusion criteria. They excluded anyone that had a previous administration of IV, intranasal, or PO analgesics in the last 24 hours. They did not exclude anyone who had only received ibuprofen or Tylenol. So you could still be included in the study if you had received one of those agents. They excluded anyone that had an allergy or previous reaction to ketamine. In terms of the past medical history of people they did not allow to be included, it was known glaucoma, schizophrenia, or a psychotic event, a past medical history of cognitive impairment, cardiac disease, uncontrolled hypertension, or kidney disease. And then they also excluded anyone with the American Society of Anesthesiologists physical class 3 or higher. They excluded anyone who was pregnant, who had active respiratory symptoms, and then finally patients with pretty major traumas or concerning presentations. And so these were people who had presented to the ED with airway instability, multiple trauma, head injury that included a loss of consciousness or altered mental status, intracranial bleeding, suspicion, eye rupture, nasal trauma, or active epistaxis. And so anyone with a pretty major presentation did not get included in this study. And then in terms of their endpoint, so their primary endpoint is probably one of the most interesting parts of this study. So what they utilized was essentially this 4 criteria that were designed to sort of streamline and standardize terminology in procedural sedation in children. And it was designed and came up with via consensus with the Pediatric Emergency Research Canada group. And so essentially, like I said, it had 4 criteria that they were looking for. The first one had to be the creation of conditions necessary to safely facilitate the completion of the procedure. And this was through attenuation of pain, anxiety, and movement or amnesia, and it had to have amnesia or decreased awareness. And so consensus was that it had to meet this criteria. They didn't define how they wanted you to meet this criteria. So the authors for this study decided to use the behavior response treatment scale. And they liked this one because it basically talked about how easily the procedure was facilitated. And so it actually describes how the procedure went. And then they also use the Ramsey sedation score, which is a validated tool. It's very well known. The thing about the Ramsey sedation score is it only measures level of sedation. It didn't necessarily measure the facilitation of the procedure itself. And so the authors utilized both of these in conjunction. And so patients had to have a behavioral response to treatment rating scale of 4 or 5. And they also had to have a Ramsey sedation score or 2 or above in order for this first criteria to be met. The next criteria was they could not have an unpleasant recall of sedation. This is harder in children. However, if children were 4 or older, they were asked whether or not they could remember if they had a bad memory of this repair. It could not have any serious adverse effects of the third criteria. And so this is any adverse effect where the events had to stop the procedure, it led to permanent complication, or it led to an unplanned admission or prolonged observation in the emergency department. And then finally, the patient could not actively resist or need physical restraint during the procedure. And so of those 4 criteria, so if all 4 of those criteria were met, this was considered a successful sedation per their primary endpoint. For their secondary endpoints, they looked at a few different things. So they looked at pain and distress for the child. They used a few different scales to assess this. One of those is the FLAC scale, which is the face, legs, arms, cry, and consolability. So basically, they look at all 5 of those standpoints to see how the patient responded. There's also the OSBDR, which stands for the Observational Scale of Behavioral Distress Revised. And this looked at a few different behaviors, including crying, seeking information, seeking emotional support, resistance, and verbal pain, screaming, those sorts of things to help categorize the patient's pain and distress. And then they also looked at time to recovery from medication administration, side effects at administration, as well as satisfaction of providers, parents, and patients over 6 years. So it's kind of interesting. They did ask not only the providers how it went, but they also asked the parents and patients how it went. And then in terms of their statistics, they did percentages for categorical or binary data. They used medians with interquartile ranges for non-normal continuous data. And then for their primary outcome, they reported it as a proportion of effective sedation, and they used a 2-sided 95% confidence interval, and this was calculated utilizing the Wald test. So looking at our results for today, for their baseline characteristics, they ended up including 30 children, so definitely a smaller study, given that it was in 2 places and it was a pediatric study, not that out of the ordinary, so 30 children included. The median age was 3.2 years old, with an age range of 1.2 to 10.7 years. The vast majority was male, so 73% of the children were male, and they had a median weight of 15.5 kilos. In terms of the amount of median volume administered, it was 1.8 milliliters. So for the most part, most people did not have to utilize the two separate administrations. And then in terms of the topical local anesthesia, 15 children or 50% received that, and then 19 children received injected local anesthesia. Over here, we have the wound characteristics. And so for the most part, most of the patients had wounds that were 2 to 5 centimeters in size. 2 patients did have wounds greater than 5 centimeters. And again, the vast majority here had head and neck wounds. So 73% or 22 patients had a head or neck wound. In terms of the sutures required, the most of them required 1 to 3, so 50% required 1 to 3. 4 to 6 sutures were required in 8 patients, and then 7 to 10 sutures were required in 6 patients. As you can see, there was a patient that did not end up getting any sutures, and ultimately what happened in this case was the patient received their dose of ketamine and then they decided to do glue, and so that patient did not actually have any sutures in their repair. So looking at this primary outcome, as you recall, it's 4 separate criteria. And in this case, 18 of those 30 patients had met all 4 criteria. So 60% of patients did have what they considered effective procedural sedation. 5 patients did have suboptimal sedation. However, they did still get their procedures done successfully. And then 7 patients had what was considered poor sedation, and 5 of those ended up needing additional agents. And so looking over here, you can see the breakdown of the 4 criteria. So these first 2 criteria are those scales, the sedation scale and the behavior response scale. You can see that the 5s and 4s both add up to 18. So these are the 18 successful kids. Looking at the unpleasant recall of sedation, it was, again, children. A lot of them were very young, less than 4 years old. And so in this case, only 6 children could respond, and those children did not remember it. So 100% success in the children that could respond to whether or not they remember their repair poorly. And then in terms of physical restriction, movement redirection occurred in 10 patients, light restriction in 4. However, important restriction did occur in 7 patients. And then finally, looking at the adverse events, no patients had any serious adverse events. And so definitely a positive outcome in that setting. For our secondary outcomes, in terms of those pain and distress scales, ultimately what they found was that the highest pain and distress was noted at the first needle poke, which is pretty expected and not something that's really different from what you might anticipate from this study. Looking at that median time to recovery, 49 minutes, which is very good, especially if you are trying to be able to discharge a patient. So these patients recovered within 49 minutes. And then looking at those adverse events, they were very minimal. 7 children did have vomiting episodes, and a couple children did have nystagmus, with 1 child requiring oxygen supplementation. So really, there were not a lot of major adverse events. Like I said, the biggest one is really that 1 child that needed oxygen. Otherwise, a few children had vomiting, and everyone else really tolerated the procedure well. There was, like I said, surveys that went out to both the providers and also the parents to see whether or not they approved of this intranasal ketamine use. And so satisfaction of providers, so 75% of them would use that intranasal ketamine at that same dose. So they did like the dose that was being utilized. And 67% agreed or strongly agreed that the sedation was effective, which is pretty on par with what the primary outcome was. If you recall, 60% of the children had what was considered successful sedations, and here it's 67, so pretty close to each other. And then looking at those parents, 89% agreed or strongly agreed that they were satisfied with the sedation. So the parents were overall very satisfied with the sedation as well, which leads me to our conclusions and takeaways and what we can take from this study. So first of all, looking at the strengths of this study, 1, the efficacy scale that they utilized translated well to sedation success. And so if you recall, there was about 60% sedation or 60% of patients that had successful sedations per that primary outcome, which is about on par with what the physicians felt and per the author's comments. So it sounds like in general, if the patient was considered successful per their primary criteria, it did actually go well, which I think is nice to see that both the subjective data does match the objective data. In terms of the ketamine dosing, I think the 6 mg per kg is another strength of this trial. It adds a little bit of a different perspective to the literature. It gives us a little bit of a higher dose so that if we are erring on the side of higher or rounding up, we feel a little bit more comfortable with that dosing. And then it also has patient-centered outcomes. They did ask the patients when they could, but they ultimately also asked the parents a lot if they thought it was successful. And I think that is another way to include your patients and make sure that, again, that subjective and objective data is matching up. And then looking at the weaknesses of the trial. So for one, I think the thing is that this is a single-arm trial, and so it's really hard to comment on the efficacy of ketamine. They had that as their primary outcome, but the reality is they didn't compare it to anything. And so not being able to say it's efficacious as compared to makes it a little bit less applicable and a little bit less of a study that would change my practice. And so I think that's one thing that I would try to change is maybe look at utilizing another agent in addition and seeing if they work better as compared to each other. So like dexmedetomidine or Versed. Also, it was a limited patient population enrolled. So most of these patients were under 4 years old. They were smaller patients. And I will say the authors did mention that the ketamine concentration might have contributed to that. They had to utilize the 50 mg per mil because that's what's available in Canada. Here in the US, we obviously have the 100 mg per mil concentration. And so I think that would have, if we had been able to utilize that in the study, it would have allowed us to expand the patients that we were reaching and reach patients who are, one, a little bit bigger, but also maybe a little older in order to kind of apply this trial to more patients. They also excluded patients in their exclusion criteria that I don't know would have been on my list of people to exclude, just given that we utilize intranasal ketamine for these patients a lot successfully. One of those being the patients with cognitive impairment. And then they also mentioned patients who had psychotic episodes in the past. And again, this is something that I think is pretty general for a ketamine study, but might not necessarily allow us to apply it to as many patients in the end. And that leads me to the application and takeaways. And so I think the big takeaway from this trial is that it is safe to utilize ketamine 6 milligrams per kilogram intranasally for procedural sedation in children. In this study, there was really only one major adverse event, and it was fixed with supplemental nasal cannula. And so I think this really gives us more comfort if we don't utilize this in our practice, more comfort to utilize intranasal ketamine. And from my end, to maybe utilize more of the 5 milligrams per kilogram versus our lower end, which is 3 milligrams per kilogram. I also think it's an appropriate first line option. So the authors talk about this, even though 60% isn't the most efficacious, what it does is it's a good first line to help us maybe try that before having to stick a kid and get an IV access. And so this is a nice option, at least first line to try. And in terms of further studies, like I said, utilizing more concentrated formulations in older or larger children might allow us to take this trial and apply it to a broader population. And so I'd love to have a little bit of discussion or questions and see what you all think and see what questions you have about this particular trial.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.